Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter anyone else that's interested, the theobspod is for you. Episode 186, Induction of Labour Update. Induction is a really hot topic at the moment. I recorded a video recently on Instagram discussing induction and it got so many hits. We know there are rising rates in the UK, and so I thought it was time to revisit this topic a little bit, particularly because there are some changes happening in the way we induce labour. Today's episode is going to build on my previous episodes. Episode 35, Induction of Labour, and episode 150, Experience of Induction of Labour. So you might want to just have a little look, check back and listen to those if you haven't already done so. Today I'm going to focus on some new developments in induction of labour because it's a few years since I recorded my episode about the kind of general principles of induction and why it's quite common. If you listen back to the episode about experience of induction of labour, there is a lot wrong with the way we're doing induction at the moment. We end up in a situation where we recommend someone has their baby because of concerns about either their well-being or that of their baby, and then we subject them to a very long, quite dysfunctional process which is limited by the agents we are able to use, as well as staffing, beds, and how ready or not their body is for labour. So in my previous episodes, I explained that whilst the evidence is there that if you induce from 39 weeks, you don't increase intervention and you may have some benefit as far as the baby's concerned, in practice that really isn't what we see. And one of the reasons that induction can be such an unpleasant experience for women is that they may end up in hospital for prolonged periods of time, and they may also require repeated vaginal examinations. Now, having a vaginal examination at the best of times, as any woman will tell you, is something that you don't particularly enjoy. Even if it's not uncomfortable or painful, it's not pleasant. So for many years, people have thought a bit about, could you have a tablet, an oral agent, an oral medication that might trigger induction of labour? And that's mainly what I'm going to focus on today. In medicine, we often talk a bit about how long it takes from evidence, so the latest research telling us how good or less good something is, to become implemented and embedded into practice. It's a really long time. I can't remember off the top of my head the average, but it's definitely 7 to 10 years. Unless, of course, there's something pushing us to change. The COVID pandemic was a classic example of that. Suddenly, many things that we'd wanted to do previously, such as remote prescribing so that women could pick up medications from their local pharmacy, or telephone or video consultations, suddenly became the norm when we were pushed to do so. We had to accelerate the change. And in some ways, this is what we're actually seeing at the moment. women may or may not be aware that there are shortages of the medication, the hormonal prostaglandins that we use for induction of labour. There's a national shortage. So behind the scenes, there are lots of doctors and midwives wondering how best to get women into labour without the drug that we commonly use. And when I say that implementation, research to implementation can be very delayed, I'm going to take you to the Induction of Labour guideline by the National Institute of Clinical Excellence. Now, this guideline is not recent, it's dated 2021. So it's been there for 4 to 5 years. If you turn to the section about induction of labour and what methods of induction of labour there are, you can clearly see that the committee making the recommendation recommend vaginal dinoprostone, that's the vaginal prostaglandins that I've discussed in my previous episode and that are commonly used, or oral, that is tablet, misoprostol. It even says, the committee note that for low dose oral preparations of misoprostol, the risk of hyperstimulation, that's overstimulating too many contractions, appears to be the same or lower than with vaginal dinoprostone. Therefore, the committee agreed that misoprostol could be an alternative to dinoprostone for induction of labour, particularly for women who would prefer an oral preparation. And it's interesting because I'm not aware of that many hospitals that are already doing tablet induction of labour. But because of the national shortage of vaginal pessaries, people are now accelerating that change. And my trust are looking into this, just as many other trusts are. It is true, there are a few early adopters, and that's really helpful. So those hospitals that have already thought about this and implemented this for some women are sharing their guidelines and their protocols for what sort of dose of misoprostol to use, what monitoring they recommend, and how it's going. So many of you could live in an area where soon the routine induction of labour offer might be to take a small dose, that's 25 micrograms, tiny dose. And in fact, that's one of the problems. We've now got to source this much smaller dose because the tablets we use misoprostol for previously, such as stimulating labour in pregnancy loss or for preventing excessive bleeding, for that we use a 200 microgram dose. So we're talking about much smaller doses here. So the regimes are that you have 25 micrograms tablet every 2 hours to a maximum of 8 doses until you get regular contractions of about 3 and 10, and then hopefully labour establishes. Misoprostol is still a prostaglandin, so it's the same sort of hormone that we're using to stimulate labour. And previously, it has been used in the maternity world for a long time, like I said, to induce labour when a baby has sadly died, or to prevent bleeding. And that's because it's very effective at causing contractions, and therefore it wasn't previously thought to be of good use when the baby might struggle with those contractions. But the latest research shows that if you use these tiny doses, then you can use it safely, the baby will be fine, and the risk of hyperstimulation, that is too many contractions, is just the same as with the vaginal pessary prostaglandins. And just in the same way as with the vaginal pessary prostaglandins, if you get too many contractions, one can give a medication called terbutaline, which relaxes the muscles of the womb. And that's something we frequently do in the current vaginal pessary method of induction of labour. So it's no different to what we would be used to doing. So I'm sat here thinking, how on earth, when we know the experience of women having induction of labour is poor, how on earth have we not managed to accelerate this change? Why is it we've had to wait for a shortage in the vaginal pessaries to move things forward? And is that a reflection on us as clinicians, or is that possibly a reflection on the barriers we face when it comes to making a change and buying the agent we need? So I say a lot of hospitals near you are going to be switching to this method, but even that is not without difficulty. Even in this moment when we're trying to accelerate change, because of this drive of there being a shortage, there are still barriers being put in place. And that's important to maintain safety and to maintain quality. But some of the barriers that are put in place as checks to keep things safe just become obstructive. Alongside using misoprostol, so that's another hormonal method, we have mechanical methods, which I did very briefly mention in my episode 35. The idea of using a balloon to gradually expand and mechanically open the cervix. Over the years, a lot of people are using something called diazepam instead. And certainly that's what my unit are using. So rather than having a prostaglandin pessary, you do need a vaginal examination for this. This is a bit like having a cervical smear test. So we put a speculum in to get a clear view of the neck of the womb, and then we put these little rods, usually 3 or 4 rods, just push them through the neck of the womb. Now this can be uncomfortable because the neck of the womb is, before labour, quite long and firm, and there's not much space to push these rods through. So sometimes you can get a bit of crampy pain when we're doing that, and sometimes we give women gas and air if they'd like that. These little rods are thinner than a pencil, they're quite small, and what happens is they absorb water from the cervix and mechanically dilate the cervix by swelling up over a period of usually 12 to 14 hours. So again, that will start to release the woman's own natural hormones, prostaglandins, and open up the neck of the womb so we can get to the point where we may be able to break the waters. So this is called an osmotic cervical dilator, in that it's drawing in water. And if you look back to that National Institute of Clinical Excellence guidance, they list it as a possible method of induction of labour. The advantage of this is that there's no overstimulating the womb. There's no increased risk of hyperstimulation, too many contractions. But they do also comment that they don't seem to be that effective in triggering labour, promoting vaginal birth within 24 hours, and I would agree with that. It's more likely that you're going to need to have your waters broken and oxytocin, syntocinon drip after you've had that diazepam, that mechanical method. It's unlikely that that mechanical method is going to be enough on its own. One of the reasons we use this mechanical method, diazepam, is that it's very good for women that we're concerned may not be able to have hormonal methods. So, for example, if you've got a scar on the womb because you've had a previous caesarean birth, or if your baby is very small and growth restricted and may not tolerate contractions very well, then a mechanical method to get the neck of the womb to open up enough to then be able to have oxytocin titrated to make sure that the contractions are just the right amount, not too much and not too little, then that can be a really good option for induction of labour. And you may want to have a listen to episode 165, oxytocin use, to understand a bit more about that. Then there is one more new kid on the block, as it were, in terms of induction. And this is another oral agent, so a tablet that you can take by mouth. And this agent is actually currently a trial called the Molly trial, MOLI. So this may or may not be available at your local hospital, depending on whether they're participating in this trial. The Molly trial is looking at mifepristone. Mifepristone works in a different way. It works by blocking progesterone, which can make labour start, and it's currently used in some other countries to induce labour. So it's something that is being used outside the UK, but not in the NHS. Those studies outside the UK have shown that in an uncomplicated pregnancy, mifepristone can be effective and safe. And the Molly trial is trying to establish this in the NHS with a larger number of women. And there are suggestions from other countries that using mifepristone may increase the number of women with vaginal births, reducing the chance of caesarean and intervention. So it'd be fantastic if that is the case and if we can introduce it successfully. The Molly trial is what's called a double-blind randomised control trial. And what that means is if you participate, you may get mifepristone, the active agent, or you may get a placebo. And you won't know which, and the healthcare professionals looking after you won't know which. So the idea of the mifepristone is that it needs a couple of days to work. So you take it by tablet a couple of days before your induction is due to start. And it makes your body more sensitive to further induction agents if they're needed. So if you then have oxytocin, you have it at a lower dose. And if you need prostaglandin, you'll have a prostaglandin pessary that can be removed. Whilst it is double-blind and randomised, I have to say, from the women we've recruited, we've got a pretty good gut feeling who may have had the active agent, because it seems, although we don't know for certain because we're blinded, that those women go into labour and the women that have had the placebo don't. But obviously that's anecdote. We have to wait for the results of the research study to be published. But we're really excited to be participating in this study, because anything that we can do to improve the experience of induction of labour, reduce the number of vaginal examinations, reduce the length of stay stuck in hospital on the antenatal ward, has got to be a good thing. So that's a little induction update to kind of keep you abreast of the current situation. What's my zesty bit? I think as healthcare professionals, it's exciting. We need to get on board with these new methods of induction. To have an induction tablet that could be taken safely by women that results in them going into labour would greatly improve the experience of women in our care. We really can't continue like this. So the more of us can adopt some of these new methods and get involved in pushing this research forward, the better. As a woman facing induction of labour, obviously you've got the same considerations as before. What are the pros? What are the cons? Why is it being suggested? What's the rationale? What are the alternatives? And obviously the default is waiting for spontaneous labour. Don't be frightened if you start to see some changes in what you're being offered. And if you're offered tablets, then that may be a real positive opportunity to experience a much more streamlined, effective process. If you're asked if you would be willing to participate in the Molly trial, of course you don't need to, but please do read the information and think about if you were willing to participate, then that could improve things not just for you, but also other women going through induction of labour processes in the future. We can only make improvements to care with your help and your consent and your participation in what we're trying to improve. I very much hope you found this episode of the theobspod interesting. If you have, it'd be fantastic if you could subscribe, rate and review on whatever platform you find your podcasts, as well as recommending the theobspod to anyone you think might find it interesting. There's also tons of episodes to explore in my back catalogue, from clinical topics, my career and journey as an obstetrician, and life in the NHS more generally. I'd like to assure women I care for that I take confidentiality very seriously and take great care not to use any patient identifiable information unless I have expressly asked the permission of the person involved on that rare occasion when it's been absolutely necessary. If you found this episode interesting and want to explore the subject a little more deeply, don't forget to take a look at the programme notes where I've attached some links. If you want to get in touch to suggest topics for future episodes, you can find me at theobspod on Twitter and Instagram, and you can email me theobspod@gmail.com. Finally, it's very important to me to keep the theobspod free and accessible to as many people as possible, but it does cost me a very small amount to keep it going and keep it live on the internet. So if you've enjoyed my episodes and by chance you do have a tiny bit to spare, you can now contribute to keep the podcast going and keep it free via my link to buy me a coffee. Don't feel under any obligation, but if you'd like to contribute, you now can. Thank you for listening.